All right, welcome. Here we are looking at feeding and eating disorders. You know, when you think about it, it's very surprising that in Canada, a country of plenty, that some people would starve themselves, even to death. In these more modern times of the proliferation of advertising, movies, the internet, social media, images of desirability all over the place, and the ability to communicate and comment on one another's images has facilitated a struggle of some people with weight, the desire and the want to be thinner. Sometimes dysfunctional and unhealthy choices are exercised in result of these modern times. Binging and purging, extreme maladaptive eating patterns are the focus of this chapter. Eating disorders like bulimia nervosa, anorexia nervosa often affect people of high school or college age, and especially women. And it's on the rise in Canada. So in this chapter, we're going to look at the types of eating disorders, the theories that explain eating disorders, and the treatments to help people in these sort of conditions. Now, many of us maybe already know somebody who's experienced an eating disorder. My sister did when she was much younger, and it has a devastating effect on their lives and the lives of family members and friends. But it is treatable, and people do move on and become healthier, have a healthier relationship with food, and a healthier relationship with the image that they carry within themselves. So let's carry on with this chapter and see what we can come up with. Now, good luck with it, and here we go. Okay, we're going to begin with anorexia nervosa, and this is an eating disorder primarily affecting young women characterized by maintenance of an abnormally low body weight, distortions of body image, intense fears of gaining weight, and in females there's a few conditions or circumstances that are related to this. Amenorrhea, which is the absence of menstruation, and another risk is osteoporosis, which is a calcium deficiency resulting in brittle bones as a result of not eating correctly. Now on page 292 on table 8.1 we'll give you some information. Now, what's important about this particular disorder is there's not a loss of appetite, but there's a curbing of what and how much food is ingested. Reduced eating and extreme exercise to achieve weight loss goals. How that goal is achieved and seemingly going lower. So that even though it appears elusive, and that is, they set a goal, they start to near that goal, and then they go lower and go lower and go lower, and not really satisfied. They still seem to think that they have weight to lose. They experience extreme denial of anything to worry about. Now, it can be quite extreme. My sister is 5'10", and she weighed 83 pounds at her lowest weight. Now, you can only imagine that's quite thin, and yet she was clear that she had weight to lose, that she was fine and healthy, and of course, she really wasn't. It took her quite a while, almost 10 years, to overcome anorexia nervosa. Now, there's two subtypes. There's the binge eating, purging type. This is where utilized to lose weight, unlike bulimia, where they're aiming to maintain weight. And then there's the restrictive type, which is an obsessive-like control over diet. Now, who's at risk for anorexia nervosa? Well, surprisingly, some of who are at risk would be competitive activities that emphasize endurance, aesthetics, and weight levels. So it puts athletes at risk for developing eating disorders. Runners who run, quite a lot. Wrestlers who have to make weight, swimmers who try to be lean, dancers in the same conditions are among athletes who have high occurrences of eating disorders. Bulimia nervosa is an eating disorder. It's characterized by a recurrent pattern of binge eating followed by self-induced purging. This is done through either vomiting or through laxatives. And it's accompanied by a persistent overconcern for body weight and body image. Now on page 294, table 8.2, you'll see the conditions by which are need to be met for the DSM-5. Now the fear of weight gain, not the desire to be thin, just the desire to be of a normal weight. Now binging, on the other hand, well, this is people with bulimia nervosa may cram thousands of calories during a single binge and then attempt to purge what they have consumed by forcing themselves to vomit. Now, of course, as you would expect, there are medical complications. Repeated stomach acids, from repeated vomiting can cause skin irritations, blockage of salivary ducts, decay of teeth enamel, dental cavities, pancreatitis, the inflammation of the pancreas, and abdominal pains from these cycles of eating and binging. Potassium deficiencies produce muscular weaknesses, cardiac irregularities, even sudden death. Now check out the normal abnormal box on the top of page 295. You'll see some differentiation that helps us understand the difference between what would be in the realm of normalcy for eating issues and what would be in the area of a concern or not normal eating. Now, if we look at some of the conditions by which we can explain, similar to other disorders, anorexia and bulimia involve complex integration of biopsychosocial, genetic, neurobiological vulnerabilities along with social pressures. And if we look at the social cultural variables, eating disorders appear to be more frequent in North America. Social expectations for what it is for men and women, to meet some sort of standard, whether it be realistic or more likely unrealistic standard. Media plays an important role in promoting these unrealistic expectations for thinness and the development of negative body images. What you're seeing here is an example of a single person in the top left-hand corner and what body image looks like for men in these different countries. So we look at the psychosocial. Here the considerations are focused on what people might be thinking and focusing on about their weight and body dissatisfaction. Now this can lead to more extreme concerns for one's body weight. Again, now on page 297, figure 8.1, have a look there. Women suffering from bulimia tend to be shy and have more psychological issues like depression and perhaps anxiety. Family issues, eating disorders, and family conflicts seem to coexist. It's not saying that they are necessarily caused by, but they seem to occur in the same households. So whether this means exerting control or punishing parents, it's arguable as to what role this family factors play. And then of course, biologically, neurotransmitter serotonin and the reward centers are considered important understanding for bulimia especially. The relationship between increasing serotonin and decreasing binging is promising. Other neurotransmitters in eating disorders are being further explored in terms of this role of impulsivity. Now, as you can imagine, as far as treatments are concerned, one of the primary would be hospitalization. And in hospitalization, this is particularly when weight loss is significant and it's dangerous. Close monitoring and regular feeding regimes are often met with resistance, forcing more mechanical, essentially feeding tubes, and chemical restraints to support weight gain. Now, this is not the only direction that they go for treatments. Cognitive analytic therapy, this is aimed at helping a patient learn new approaches to their food and eating, and this often takes a long time because you're fighting a very significant resistance in terms of dysfunctional thinking, and some of the rationale that has been offered has been, the role that control plays. That if a young person has felt not in control of anything in their life, the one thing they control is what they put in their body, and so some of this is around reestablishing good and healthy good and healthy perspectives about oneself. Now there's also family therapy that's involved, and this is an attempt to identify and resolve any of the family conflicts or parenting styles that can assist the patient in getting healthier and better. Cognitive behavior therapy is the pairing of correcting faulty thinking with an almost phobia treatment strategy. So it's about new mindsets and getting new results and re-establishing through cognitive, your thinking, and behavior, the things that you do, therapy. And then lastly is the interpersonal psychotherapy. And this is an alternative to cognitive behavior therapy, where the focus is on the interpersonal conflicts, the conflicts within the individual, and establishing, the conflicts they have with food, and establishing a healthier perspective about the relationship with food. And again, these sorts of treatments can take quite a length of time, and it's probably in part because it's a very significant issue in terms of health. Now, if you look on page 302, you'll find under the closer look other eating problems and related conditions. These are the ones related to infancy and early childhood. Now, some of these will carry on into adulthood. Pick-a behavior is one. Again, these definitions are going to be in your book. Rumination disorder, feeding disorder of infancy or childhood, Prader-Willi, and cyclic vomiting syndrome are examples. Now, if we carry on and look at what could happen in adulthood and adolescence, anorexia athletica, muscle dysphoria, this is also known as bigorexia, orthorexia nervosa, night eating disorder, nocturnal sleep-related eating disorder, and gourmand syndrome are all examples of other subcategories, if you will, of eating disorders, and there's a range of them. For something that is so common, if you will, in our lives, and like I said earlier in the introduction around, we are a land of plenty, it is surprising to some degree that there's as many eating disorders, or maybe it's not surprising that there's as many eating disorders as there are. All right, I hope you have found this a useful and helpful chapter. And next week and the week after, we're going to look at schizophrenia. All right. Good luck, everybody, and thank you.